Category 1, Craniosacral Dural Dysfunction. This was an article that was sent to me by the president of SORCI back in 1985, and it's all about the fact that these brain scientists at the University of Maryland Medical School discovered that there must be some sort of a pump to pump cerebrospinal fluid through the brain. When injected with a dye, the CSF made its way to the center of the brain in a much faster time than would be predicted by diffusion or sinking in. And when SORCI contacted these scientists, they were astounded to learn that there were any healthcare professions that sort of assumed that that was true before they had made their discovery. Dr. Tom Gregory was a postdoctoral student in the brain lab at the time, and he's now a chiropractor. He actually wrote the first book, the first peer-reviewed paper from an SOT perspective. It was on TMJ and the SI joint. There's been various theories regarding cerebrospinal fluid in the past, before we had the technology to actually determine how does it really flow, how fast does it flow, what kind of pressure, etc. And one of those theories is that head movement through the myodural bridges that connect the dura mater to the muscles in the upper neck had something to do with it, and that's what this article. There's a variety of other studies that have studied CSF flow, and since real-time magnetic resonance imaging has come online, we can now actually see CSF. That shows that, as is that. Theories put forth. This was sort of interesting to me. I never knew fish got scoliosis. But evidently there's a fish called a zebrafish. PTK7 mutant zebrafish can get scoliosis. And this is a theory put forth in Science that the CSF motility has something to do with cilia in the different cisterns of the CSF on these fish, and that may be true to some degree, at least on zebrafish. I thought this was a pretty funny picture. Mark Pick, who I referenced earlier, talking about the neurology of the arm fossa test, creates these amazing rubber models of the spinal physiology of the body related to SOT, and he creates them by real human dissection and creates rubber models that way. Some of his models are in a museum in Paris for anatomical accuracy and just plain old works of art. And I was at one of his lectures one day, and he showed me this thing. And what you do is you squeeze those balls at the tail end, and each ball represents a different motion of the sacrum. The air pressure is contained within the dural tube that goes all the way up to the skull. And you can actually see that when the sacrum moves in certain directions by squeezing the ball, different parts of the head move in a reciprocal motion. And it was just an excellent learning tool. The Category 1 anatomy that we're most interested in is basically this. The sacrum is functionally connected to the cranium via the dura mater, which attaches from S2 down to the coccyx, and then attaches to the superior part of the posterior arch of atlas. It attaches to the foramen magnum. It attaches inside the skull in the form of the falx cerebri and tentorium cerebelli and falx cerebelli. And it lines the inside of the skull in the form of the periosteal dura. It actually runs through the sutures and becomes the periosteum on the outside of the skull. So from a functional point of view, there is a relationship between sacrum and occiput. And that's where SOT gets its name. So anyone who believes in the foundation principle of chiropractic, which basically says that if the bottom is straight, there's more of a chance the top will be straight too. Look to the SI joint, look to the lower extremity. Think of the bottom, the SI joints, as being the mechanical generator. And think of the top as being a compensator with a vestibular mechanism and the container of the brain that sends back information. How well is the bottom doing? And that's sort of the way I look at it, especially from an. Here's my Category 1 patient lying face up on the table. You can see the giant dural structures inside the head. So the vast majority of the dura mater attaches to the skeleton inside the head. And then the second greatest attachment would be at the sacrum. And it's this connecting link between the top and the bottom that fascinated Desjarnais, that sort of guided his treatment of patients. 5 phenomena of the primary respiratory mechanism. The primary respiratory mechanism is a term that you'll see quite a bit in osteopathic literature and craniosacral therapy literature, and sometimes referred to in SOT. It's called primary because it begins before birth. It's called respiratory because it involves a pump, and it is a mechanism. So the old osteopathy books that I referenced for this information consider that it has 5 sources. The motility of neurological tissue, primarily glial cells that are found in the brain and spinal cord. The rhythmic fluctuation of cerebrospinal fluid as far as speed and pressure. And now that can actually be measured. We know that the dural membranes move. They're attached to the spine, so they have to move. And they contain the cerebrospinal fluid. There's a minute amount of articular mobility between the sutures of the skull. Craniopaths feel that they can actually feel that mobility. I'm pretty convinced that what I'm actually feeling when I feel so-called restriction is a lockdown of fascia and musculature over the fascia. And I feel that that lockdown in so many cases is actually secondary to SI joint dysfunction. It's compensatory. If there was a head injury or a severe neck injury, as in a car accident, maybe a concussion, then I can believe it's really primary. But I think in most cases when we feel that, it's secondary to something below. And there's even been some studies done on exactly how much do sutures move. They've only been done in cats, and the answer is not much. And then we know that the SI joint does move. The sacrum with respect to ilia actually moves 2 or 3 millimeters, 2 or 3 degrees of rotation. Also, again, not much. So I think it's important to keep in mind when we're comparing one side of the pelvis to the other, when we list something like a PI, that we're really listing posterior and inferior with respect to the other side. There's a flow of procedures for this category. We start with a cranial procedure called Basic 1 cranial. And then we go to checking heel tension and a short leg in the prone position. If we have heel tension and short leg on opposite sides, you must adjust atlas. That is an interesting finding from SOT that ends up being the most pathognomonic indicator of atlas dysfunction that I'm aware of in any chiropractic technique. I don't know a more pathognomonic indicator. After you've adjusted atlas, or if you found that heel tension and the short leg are on the same side, you may block the patient, Category 1 style. It's done prone, and the patient is passive. Then you can check the musculature or muscle imbalance of the low back muscles in what's called the dollar area, which is the mid-gluteal area, and the crest area, which is the area above the iliac crest. The dollar sign stands for dollar area and the crosshatch for crest. You can also check for so-called vasomotor dysfunction, which is dural stress having an effect on blood flow in the subcutaneous vasculature over the spine. And next week I'll cover how you find that and how you adjust for that. And finally, we're going to look at the relationship between all that compensatory change in the neck and in the skull, where it's located, and what its relationship is to possible dural function and autonomic imbalance in your Category 1 patient. Category 1 people usually complain of mid-spinal pain, right, not left or right, just right in the middle. Could be low, could be middle, could be upper, but it's not left or right. And visceral issues. Basic 1 cranial is a sensitivity exercise on the part of the doctor. All I'm doing here is feeling any activity on the back of the patient's head, and I'm comparing left versus right. To me, it feels like energetic differences. You might feel pulsations. You might feel a difference in temperature. It might feel heavier on one side than the other. It might feel like, this is what it feels like to me, it feels like little tiny ants are running around between my hand and the back of the patient's head, left and right. There's just more ants on one side than the other. And I would like to balance this out. And when I hold the patient's head long enough, eventually the muscles in the back of the head relax to the point where the cranium has actually let go of some of its compensation. We would like that to happen before we go down and block the patient. This procedure is done supine. There's not much activity on the part of the doctor. There can be. There's things you can ask the patient to do. So one thing we might ask the patient to do if we don't feel equal sensations in our hands is to take a breath in, hold it, suck on the tongue, dorsiflex the feet. Another thing we can ask them to do is let their head go, and we will just rock the head towards the side that I don't feel as much sensation in my hand. Now, you might need to hold the head for 5 full minutes to get both sides feeling equal in temperature, weight, pulsations, etc. The only thing I caution you about with this procedure is make sure that you're not just feeling pulsations in your own fingers, because that's you. That's probably not the patient. Desjarnette would say that this procedure prepares the cranial vasculature for blocking. And by that, I think he means that blood flow in the head is good enough after you do this, that when you correct the sacral pump by mobilizing the synovial part of the SI joint with prone blocking, the cranial vasculature can handle the change that's going to come. So now and then when you adjust somebody, and it doesn't have to be in the neck or the upper cervicals, it could be in the low back, they'll tell you that they just got a rush of blood to their head. That's true, they did, because you affected autonomic balance. Always keep in mind cervical and pelvic is parasympathetic, lumbar and dorsal is sympathetic. So you could give a pelvic adjustment, especially if you're adjusting sacrum. That's the hotbed of the parasympathetics. And basically, you hold until the pulsation is felt bilaterally and equal, or whatever other sensation you're picking up. I think what this does is the warmth of your hands and the constant doctor-patient contact enables the patient to relax their traps and SCMs to the degree that the fascia over their skull relaxes and blood can flow more easily. This is called Basic 1. It's the first procedure we would do on a Category 1 patient. I urge you, and by the ankle I mean the calcaneus. I'm actually distally stretching the calcaneus towards me. The foot will go into dorsiflexion when you do that, but I'm not trying to dorsiflex the foot. Okay? So it's traction on the Achilles tendon. It may be tight, and that's called heel tension. Due to, in the presence of dural stress, there's probably decreased inhibition of the gastrocsoleus muscle group, which is a posterior muscle group below T6. We think it's possibly secondary to dysfunction or imbalance in the pontomedullary reticular formation, which is, of course, the pons and the medulla, and it's this sort of disorganized web of nerve cell bodies that are responsible for excitation and inhibition of muscles. And I covered the theory of A-to-P sway and heel tension in the categorization part of this course. So this would be a good time to go review what I said about decreased inhibition. This is a couple of pictures that were sent to me by Chris Kent. He's a chiropractic scientist of sorts and a researcher, and it's quite amazing. This is functional MRIs showing a metabolic brain activity before and after an upper cervical adjustment. And it was activity registered by the detectors in the MR when she dorsiflexed her left ankle, almost as if we were doing heel tension. Okay? It has not been published. I've been in communication with Chris. This study was not published. So what you're seeing is a slice of metabolic brain activity here. This might have been a PET scan. I'm not sure. Before the upper cervical adjustment, you have a slice of brain that showed all these bright spots. That's how much brain activity was occurring during dorsiflexion before the adjustment. After the adjustment, a lot less brain was involved in doing a rather primitive neurological function of ankle dorsiflexion. On the next set, you can see the after the adjustment. At this slide, there was no brain activity. Dorsiflexion is part of walking, and that should just be almost brainless. That should be almost completely conducted through the spinal cord itself. There's some proprioceptive feedback, but it shouldn't take all the brain activity that you see on the left. That's very inefficient neurology. So I think what we're seeing here is a visual picture of neurological efficiency achieved after an upper cervical adjustment, which we always look at in category. In SOT, we recognize two atlas possibilities. One you might call an ascending restriction. So in other words, you would find a restricted atlas on Mopal. It would be fixated. But that would be secondary to something below, usually, and is considered less important from an analytic point of view. If it gets adjusted, that's fine, and if it doesn't, that's also fine. And then you would find the primary atlas descending involvement, where atlas is actually causing changes in what you see when you analyze the pelvis. And this is one of the reasons why in a Category 2 we always check atlas to make sure that we get UMS or LLL, because atlas can change pain perception and it can also affect the supine short leg. In a Category 1 patient, we want to make sure that we have heel tension and the short leg on the same side. And if we don't, we need to adjust atlas. So if you have heel tension on the long leg side, which is checked prone on a Category 1, you need to adjust atlas. Now you could go up and Mopal the atlas and adjust it with a supine cervical set, a sitting cervical, a Gonstead cervical chair, or a toggle. But in SOT we have a very specific and unique way of adjusting that atlas. So the primary atlas is more important analytically in SOT, and it's called a descending involvement. So to determine that you actually have a descending atlas involvement, meaning an atlas issue that can screw you up when it comes to leg length analysis, block placement, and the side of heel tension, have the patient turn the head in this illustration to the right, but also in dotted lines to the left. The side they turn to that causes the leg length difference to increase is the side that they're going to turn from going back to neutral during this atlas correction. This is an example of the patient actually self-adjusting with the help of the doctor. So you have the patient turn the head right and left as you do a prone leg check with traction. And the side that they turn to that makes the leg length difference greater is the important side that you want to remember. So if cervical rotation affects leg length, you found an atlas that needs to be self-adjusted by the patient. If there's no change during head rotation, you don't really have to worry about atlas immediately, especially before you block. But with a descending atlas, you do have to clear that atlas involvement before you block, because the existence of that atlas subluxation can create a leg length difference that's on the wrong side, causing you to block backwards. And that just won't work. Now, if leg length imbalance becomes more pronounced to the right or to the left as the patient turns the head right or left, then you need to do this. Now, if you have a really bad atlas involvement, sometimes you'll try this procedure and it really won't work. So you're going to have to go on and up, and you're going to have to osseously adjust atlas. So what the patient does to help you, actually to self-adjust, is they traction up on the table. Their head is turned to the side that made the leg length difference worse. You grab the long leg side, which should be the side of greater heel tension, and you traction that long leg side as the patient turns their head to neutral, from the bad side, the side that made the leg length difference worse, back to neutral. You try it 3 times. If 3 times results in the same finding, in other words, when the patient turns the head, they still get worse, in other words, head rotation affects leg length, that shouldn't happen after 3 reps of this, but if it does, go up and osseously adjust the atlas. This illustrates how you should traction the long leg side. You're stretching the Achilles tendon. And this is repeated until there's no change in increase in leg length discrepancy. If that finding still exists when you tried this, then go up. There's an osseous component to the atlas issue, and you need to adjust osseously, usually supine. Okay?